My name is Gregory Vidal, breast medical oncologist at the West Cancer Center and Research Institute. I also direct the clinical research program and the breast cancer program, and then an associate professor at the University of Tennessee Health Sciences Center. And my esteemed colleague.
Hi, I'm Nusayba Bagegni. I'm one of the breast medical oncologists at Washington University in St. Louis. I'm an associate professor of medicine. I oversee the breast cancer clinical trials portfolio, and I'm associate medical director of clinical research for the Division of Oncology.
Well, thank you. We're going to have an exciting conversation today about the landscape in the HER2 positive in the metastatic setting, mainly DB09, and give some of our impressions of this. This is going to be sort of a conversation. I will start the question and we'll go from there.
Yeah.
All right. So, HER2 positive, first line.
Yes.
The standard has been CLEOPATRA.
Right.
All right. Tell me your impression of how this regimen has really shaped the HER2 positive metastatic space.
Yeah, so well over a decade, the first line therapy has been well established as a taxane plus trastuzumab, pertuzumab. And, we have induction trastuzumab, pertuzumab with taxane, followed by maintenance trastuzumab, pertuzumab. We tend to then, for those with ER positive, HER2 positive breast cancer, incorporate endocrine therapy, which actually wasn't allowed initially in the CLEOPATRA trial. And we have many patients that really do quite well with it and tolerate it well. And we saw overall survival data, and we had a number of patients that still continued on at the final analysis. And so that has been the first line, standard of care for over a decade.
Yeah. Can you comment on sort of that tail that we see with just antibodies?
Yeah.
Because, again, to sort of introduce the new trials in that sort of context.
Yeah, I believe as far as out of 8 years or so, there was 37% of patients that were still on and still alive at that time. And you still have that tail of patients. And we've all, I'm sure, have these patients in clinic where they continue on trastuzumab, pertuzumab. And the question is, do we stop? And now we're designing these studies like the STOP-HER trial to determine, are there patients that we've potentially cured? And I think of all of the breast cancer subtypes, this is probably that subtype that we might be using the C word. And so definitely a tail, which then with newer data, that really kind of shakes the landscape a bit.
Yeah. Do you think, what do you think are unmet needs in that setting, considering CLEOPATRA?
Right. So I think, for patients who have a short disease-free interval, right? So if they had received like a taxane, trastuzumab, pertuzumab in the neoadjuvant setting, and then have a short disease-free interval to metastatic disease, then we tend to not want to use a taxane-based regimen in the first-line setting. I right now tend to go to T-DXd in that space, especially in patients who've had, TDM1 in the adjuvant setting. I think the other is some of our patients do have neuropathy after like docetaxel, carboplatin, trastuzumab, pertuzumab. And then they might get TDM1. And then when you come to the first line setting, giving a taxane, there's issues there. And then the other, I think the big one is CNS involvement. And so we definitely need therapy options that have good CNS penetration. We don't really see a lot of that with THP or patients who have really high, visceral burden, visceral disease burden. I think those are areas of unmet need. I could go honestly on and on. I think those are the keys.
I agree with you. The question then is, knowing that we have patients who have done so well on CLEOPATRA, patients who are still on antibodies for a long time, when we're thinking of new trials, again, we don't cure everybody. In fact, we hardly mention the C word in that space. So which means there's still an unmet need.
Right.
What sort of endpoints you think are important, specifically in that space when you're designing a trial?
So, one important aspect that we've looked at in the DB09 trial is complete response rates. And so if you're talking specifically about can we get to that C word and advanced HER2 positive breast cancer, looking at CR rates and seeing if there are more patients that if we introduce this therapy in the first line setting, could we get to that in more patients? Other things I think that are important are obviously durability of response. And then, toxicity, because like you said, for most patients, at least in 2025, we're not able to cure their disease.
Yeah.
And so we really have to really focus on making the therapy as manageable as possible and really having meaningful quality of life.
Let's talk about DB09.
Yes.
Destiny Breast 09. Can you give us a description of what that study is?
Yeah. So DB09 was a first-line trial that enrolled patients who had either de novo or recurrent metastatic HER2 positive breast cancer. It was roughly about 50-50 in terms of ER positive and ER negative, which is tends to be what we see. And these patients either received the CLEOPATRA regimen, a taxane, trastuzumab, pertuzumab, or trastuzumab deruxtecan, or what we're going to call T-DXd plus pertuzumab, or T-DXd alone. So it was about 380 roughly per arm, and patients were randomized 1:1:1 to receive one of those treatment arms. And then we looked at, the key clinical endpoints of progression-free survival, overall survival. Obviously, we always think about CNS disease and, looking at that, clinical benefit and complete response rates and quality of life measures and safety. And so what we found at ASCO, we had the initial data that was presented. And so for the T-DXd monotherapy arm, that data will be presented with a few, the final analysis. But we heard the initial data from T-DXd and pertuzumab versus THP, and we found about 40-month progression-free survival with the T-DXd and pertuzumab arm, where it was about 27 months with the THP arm. And so that was a nearly 14-month difference in terms of progression-free survival. And I think many of us had expected that based off of, the second-line setting that used to be TDM1, and then DB03 moved that up into the second-line space. And so, the next kind of logical thing was, what about moving it up into the first-line setting?
And yes, so I personally wasn't surprised by the results, that it was going to be positive.
Yes.
And the question was always, when we saw Patina,
yes,
can we match that?
Right.
And for talking about Patina was in the ER positive space, patients who had gotten response on CLEOPATRA then get added palbociclib and hormonal therapy in that setting. And we saw like a 44 months.
Unbelievable.
Yeah. But what also is important is when we look at the control arm for both T-DXd and Patina, they were doing so well. 26 months.
Right.
I am going to contrast that not only to CLEOPATRA, but what we saw recently here, the HER2 CLIMB-05,
right,
where the control arm is 16 months. What do you think is the difference?
I've been trying to digest that information since we've gotten it. The one thing about the HER2 CLIMB-05 is similar to Patina, patients had induction therapy and then they could not have progressed, right? They needed to have at least stable disease. So you have to count into that. And I believe it was 48 cycles of THP and they couldn't have had progressed. So you have that lead in. So if you add that to the 16 months or so, then it could be kind of on par with the THP, the treatment of physicians, the THP arms for the others. And so initially I was like, okay, this is, it's less, but you have to think about it, which makes the Patina trial even more impressive, right? Because those patients also had to have induction and then not have progressed, and the objective response rate was about 69%, and then they moved on. So then you're adding on that 20 plus months, right?
And so the difference there between Patina and HER2 CLIMB-05 is the amount of patients who are hormone receptor positive who actually got anti-hormonal therapy.
Right.
That was 45% relating to
Right.
but that was 100%.
It was 100% Patina.
And whether or not that made a difference. But again, the control arm is at least makes me think of whether or not we're still having the similar population of patients.
And it makes you also wonder in the DB09, we didn't, for patients who got T-DXd and pertuzumab, only about 13.5% or so of patients also got endocrine therapy, and they allowed it after initial induction. Right. But also for THP, less than 50% had actually gotten endocrine therapy.
Right.
So whether they had also gotten endocrine therapy in the maintenance setting, the data may have been more impressive.
Anti-estrogen therapy was not mandated in CLEOPATRA.
Yeah.
And so that could also impact that. All right. Assuming DB09 is approved, we have Patina.
Yeah.
We have HER2
Right.
We have DB09, and we still have CLEOPATRA.
Yeah.
Do you have a sense in your mind which patients you're treating on the either of this regimen, or are you doing a mix? What is your thinking process?
So Greg, this is the big question,
this is
right?
the big question.
Maybe I should turf it back to you.
I'll give you my opinion.
So I've already started having these conversations with patients because I think it's important to, be timely and talk through the data. Obviously, it's not approved, as you mentioned. I will say that it used to be a pretty straightforward conversation, right? We had the CLEOPATRA regimen, right? You had the CLEOPATRA regimen, and then over the past year, since we've seen Patina, if patients had ER-positive disease, then we would talk about the Patina regimen. So I would say that I do think that the Patina regimen, in terms of tolerability and so on, I think that's really, really a critical regimen to have for patients. And I think many patients, we've all had them, can do quite well with THP. And the fact that you're giving endocrine therapy and you're giving, you're blocking HER2 and CDK4/6, that crosstalk, I think that biologically makes a lot of sense.
So you're sort of separating the hormone receptor positive.
Right. Whereas before it was kind of a one size fits all. Now I think that we're going to start to become a bit more kind of biomarker driven over time. The biomarker may now be HR status. But perhaps, we all have those patients that don't do as well on THP induction maintenance. And so, who are those patients? So perhaps if the tumor is associated with a PIK3CA mutation, then those are patients that perhaps we may need to start with the DB09 regimen, or patients who have a short interval, disease-free interval. Those are patients that I'm already considering T-DXd in the first line. And so those are definitely patients that I would offer this, whether I'd offer it with pertuzumab or not in that setting with a short disease-free interval. That's something that we're going to have to digest. CNS disease as well. Yeah. We don't tend to screen the brain. And there's kind of a lot of debate about
and maybe we should.
Staging, and perhaps, perhaps we should at this point to help kind of, figure that out. Or patients who you really need a response now. And if patients have de novo versus recurrent, and again, that disease-free interval. So I think it's going to be more nuanced than it was.
Are you thinking you need to see T-DXd only arm to really finally solidify? Because I do.
Yeah.
I think if T-DXd, the fact that we haven't seen the data, low events, may suggest that it's probably going to be a positive.
Yeah.
And I do think that if you T-DXd only, if it has this sort of similar activity, really sort of maintains CLEOPATRA for a next line.
Right.
But because you don't have pertuzumab there.
Right.
But if you give pertuzumab in the first line, you essentially has gotten rid of CLEOPATRA, because who's going to re-challenge with CLEOPATRA in the second line, at least without data. We do have some small data set, but we would need better data for that. So I think that population, for sure, I would need to see that. But if it's approved, I do agree that those high-risk patients, the PI3 kinase mutated patients, I think that's a DB09 patient
Yeah.
for sure.
Yeah.
The hormone receptor positive patients, I'm now starting to think of them as different.
Yeah.
All right. The question in my mind is, do we do CLEOPATRA?
Yeah.
Chemo induction?
Yeah.
With sort of a Patina approach, or do you do a DB09 induction approach?
With a Patina maintenance.
With a Patina maintenance, what do you think?
Yeah. I do think that ultimately, T-DXd, although, it's an ADC, it still comes with chemotherapy-like side effects, right? And so I do think that we will likely be doing some sort of induction maintenance and then thinking about, how can we get the best response possible and target all the pathways that we know are activated. And, obviously we're going to go way off and we're not following any clinical trial data at that point. But, I think in the real world setting, we may be doing those types of things, especially if a patient develops ILD, right? So we saw 2 fatal cases of ILD in the DB09 trial. And so, I've had patients where if they have grade 1 and it doesn't resolve, or grade 2 and you can't re-challenge as of now, or there's a lot of hesitance, then maybe those are patients that you could drop, kind of shift over and do the Patina-like, or for ER negative, potentially bring in tucatinib or keep HP going and then consider HER2 climb, the original HER2 climb after the fact. So,
and we have to think about this. This is on the DB09. If you follow that, those patients are going to do well.
Yeah.
For a long time.
Right.
And there's a cohort of those patients. And that would be chemotherapy.
Yeah.
With the symptoms that comes with it for a very, very, potentially very, very long time. I do think the authors and researchers have to help us figure that out, because practices, physicians are going to make this up.
Right.
And so that's very important when we talk about this. From a side effect perspective,
yes.
Any sort of management strategies that you use with the DB09 sort of regimen, or you can think of? I don't know, did you participate in the study at all?
Yeah, so at WashU, we actually didn't participate. But obviously a lot of familiarity with
T-DXd and pertuzumab separately.
Right, exactly. And so, we're familiar with the toxicity profile and management. I do think that I was thinking about this as well. So I think that because of the toxicities that we could see with T-DXd, probably the follow-up in clinic is going to be more significant, right? Because usually you do induction, THP, maintenance HP, and many times you're not necessarily seeing these patients every 3 weeks for treatment, but it's likely going to shift with DB09 because of, toxicity assessment and management. And
that's a very important point that I hadn't actually fully thought of, because you're going to at least have to see those patients maybe 2-3 weeks for the first maybe year. Which would be different otherwise. So that's an additional cost, and also patients, have to be tied to the clinic for a long time. ILD management. How do you currently approach that?
Yeah, so we follow kind of the 5 S's, right? So it's important to really inform the entire team and the patient being the key in the team, about watching for any types of symptoms. But obviously when we have symptoms, that means we're at least grade 2. And so it's really going to be important to screen. And so I do tend to get pretty regular serial CT imaging of the chest and monitor very closely. And then if we do have just radiographic findings, then I stop, and I tend to start steroids pretty promptly. I think the faster you can allow it to resolve, the faster you can get patients back on therapy, and hopefully prevent, delays and other issues. And so, I've participated in a lot of the T-DXd trials, and so I usually follow kind of what the protocols called for. So less than 28 days, resolution. I'm usually getting a scan at like 2.5 weeks, 3 weeks. That way I can, act in between until early. And then, seeing where things are, and then re-challenging and following patients very closely. I've had certain situations where there's enough ground glass opacities that I may actually, when I re-challenge, with a little bit of prednisone on board. Not necessarily for everybody, but I have considered that for some. And then, follow those patients. If it takes longer and it does eventually resolve, then I will dose reduce.
Right? What do you do in terms of frequency of scans?
Yeah. So I do tend to do it every nine weeks. Every 6 weeks is a lot. Patients feel like they're constantly going to the radiology department. I know most of the studies did every 6 weeks. So every 9 weeks over time, although when we look at the prior T-DXd trials, it can be that first year where it can develop, right? So you're not off the hook. In some situations, we may go to every 12 weeks, but again, we're following patients very, very closely. What about you? How often do you scan?
I tend to do at least for the first 6 months.
Yeah.
So 6 to 12 months is sort of where we see most of the T-DXd happening. So I tend to do Q6. I have to agree, it's hard for patients to come in and do that. Yeah. And then depending on my concern, at 6 months I could spread it to every 3 months, or 9 weeks to 12 weeks, or wait at 12 weeks to spread it out. But I try to do it a little bit more frequent up front for the main reason you mentioned it earlier. If you're grade 1 and it resolved, you can re-challenge. And we found from data that's been presented that I think at ASCO, Perigo presented re-challenge, where most of those patients who were grade 1 when you re-challenge never have it come back. Which otherwise, if they were grade 2, although she had a small cohort who was grade 2, but current standard is you don't re-challenge that population. But if you don't get it at grade 1, then those patients then lose the ability to get this potentially life-prolonging medication. So that's how I do mine. All right. So I think, in my mind, DB09 gets approved. That's standard. I am going to, a lot more of my patients will get that. The hormone receptor positive would have to think about them a little bit different. But I am going to think about that patient for T-DXd, okay? How do you counsel your partners as the breast expert? Or I'm assuming you do a lot of second opinions from community. How do you counsel them to say, well, one, you can be comfortable with using DB09 in the first line setting, mainly because it appeared very active, but also safe for most patients. Because there are some physicians out there who are concerned about that toxicity.
I will say that my impression has been, and kind of interacting with my community colleagues, that, we've had a lot of experience now in the breast space, and now T-DXd has been approved in other settings as well. And just DB06, you have a larger patient population with HER2 ultra low and low. There's a lot more experience with T-DXd. So I think the main issue is really watching for symptom management, right? And watching for any toxicity, so kind of the regular chest CT imaging and so on. My impression is that many of us, we already understand the potency of this agent. And so there will likely be adoption of this. I think that there's going to be some hesitance in terms of how long do we go? And, just the relative ease of doing an induction followed by maintenance. The efficacy data is pretty profound, and I think many of us do follow that data and then sit down with our patients and have that conversation about where to go. If we didn't have the Patina, trial, then it would be very easy, right?
Yeah.
But with Patina and just the differences in toxicity and I think overall quality of life, that's where it's going to be more of a discussion with the patient and so on. But I do feel like at least my community colleagues, I think that many of them have had a lot of experience because we have the DB06 and that's a much larger patient population. I would say that if it was a few years ago, it may be a bit more, there may be a little bit more hesitance.
My colleagues and those in the community, I work in the community also, they're excited about T-DXd. There's some fear about it, but since DB04, there's been some excitement around it. And my only concern is if you're going to use it, you have to pay attention to the population, who you give it to and their symptoms.
Yeah, and like we said too, sorry, Greg, as we said, it's really important to, follow those patients, and it's going to be different for the clinic workflow.
Yes.
Right? So it's going to require more touching base and really following for that ILD and others. And that's, I felt the same way with like the adjuvant ribo data, right? Because many of these patients you're not seeing after a certain period of time. So that's going to be a big shift.
We talked a lot about ILD. What about nausea?
Yes. So very early from the initial approval of T-DXd, we realized that it was not really moderately emetogenic. It was highly emetogenic. So it got bumped up in the anti-emesis guideline for the NCCN.
What is your experience once it got bumped up?
Yeah, so I do tend to pull olanzapine out. So I'll use like a 5-HT3 and an NK1, and then obviously dexamethasone. I tend to have patients take dexamethasone for a few days after, and then quickly bring in the olanzapine. I don't tend to start it for all patients right away, unless I know that in the past they've had issues with nausea. Then I may say, right off the bat, let's use it as part of the prophylaxis. But
so you do the 3 to 4 drug regimen.
Right.
Yeah.
I've seen more of that delayed nausea and vomiting, and the olanzapine works beautifully for that. And sometimes even dose reduction.
Yeah, I have to say, the first time I used the drug, when it first got early approval, I was most surprised by the level of nausea.
Yeah.
But once it got bumped up, and we started having appropriate anti-nausea, the 5-HT3, NK1, steroids, at least those 3, and then olanzapine, sort of the nausea is really not as impactful.
Yeah.
And we have patients who have really good quality of life on this regimen.
Right, completely agree.
So, yes. And dose reduction is always an option.
Yeah.
All right. So let's talk a little bit about sequencing in the HER2 space. All right. So a scenario where out of a little bit off of T-DXd, because I do want to get an opinion on if you took a T-DXd induction approach, all right, and you went to sort of Patina, and on progression, what are you doing?
Yeah, I haven't done it yet. So, but what would I do? So I would be thinking about the HER2 CLEOPATRA regimen.
Okay.
Right, with tucatinib. I think that's still an important regimen to consider.
Are you not rechallenging with T-DXd?
Rechallenging. So I haven't done it yet. But,
So that patient didn't progress on T-DXd. So you did a...
So I've done an induction. Yeah, then I think it's certainly reasonable to consider rechallenge. It's kind of like right now we don't have the DB09. As of today, whatever today is, we don't have that approval. So some of us might consider THP, and then, if they have a long response on HP or stability, sometimes you might consider, do I rechallenge with a taxane and then keep going? So I think, So, I think it certainly, would be a consideration, rechallenging, or as long as it wasn't due to toxicity like ILD or something. But then, the question of, do I bring in a taxane now? Do I bring in tucatinib-based regimen with CAPE and trastuzumab? Obviously clinical trials, and because everything's going to be flipped on its head right now in terms of our usual algorithm. And then, we also have traditional chemotherapy and mirvetuximab and trastuzumab combinations. So that's another potential direction.
I always get concerned that, we do these studies, and studies tend to be sterile environment, very prescriptive.
Right.
And we get this 40 months median progression-free survival. And then we make changes clinically. Different scenario, you use the T-DXd, DB09, and T-DXd and pertuzumab approach, and then on progression. I think you sort of hinted at it earlier. What do you do next?
Yeah.
No CNS.
No CNS. Yeah. So I think, I think it really depends on what they've seen prior. Is this de novo or is this recurrent? Because the question is, it's going to be tough to give a taxane for a long, long time. And that's actually why we had CLEOPATRA induction maintenance. And you've already given T-DXd as kind of the trastuzumab-like. So I do think that either TH or the HER2 climb regimen, I think those are going to be important. Or, we did have some, if it's ER positive, we did have some of those trials with CDK4/6 inhibitors. And I've done this in later line where I've combined, either palbo or ribo or abema with trastuzumab. So again, it's not as, we don't have this really good solid algorithm anymore.
Yes, I totally agree with that, because, we had T-DXd third line, moved up second line, moved up third line, and all of the drugs that we had ahead of it likely hadn't been studied in the setting of T-DXd, so you don't know what's after. But in my opinion, I think that second line becomes a HER2 climb population. With or without CNS disease. There's overall survival of HER2 climb.
There's overall survival, and patients with or without CNS disease benefited.
Yeah. And if there's CNS disease, even stronger support for HER2 climb regimen. The TDM1 is kind of sad. What's happening to that drug? Because it's well tolerated in that population. Where do you put it?
Yeah, so I've had some patients where I've actually, we have phase 1 data with TDM1 neratinib. Obviously we have the TDM1 tucatinib data that was presented a few years ago, right?
That's San Antonio.
At San Antonio. So that's a bit of a tough one, I think. But we have phase 1 data for TDM1 neratinib, and I've had, CNS metastases becomes a big problem over time, right? About 50% of patients will will have this and succumb to it because of CNS disease. So sometimes you have to get kind of creative and bring the combinations together. But I think that, we really advocate for clinical trials. So if we don't have a clinical trial, you're going to want to use all the options that you have available. You're going to follow patients closely, because we don't know how patients will do in a large setting. We don't know how they'll do after exposure to a very potent ADC with TDM1. And so this may be when we start doing bispecifics, right? And there's a lot of interesting molecules that are in investigation, or other really novel ADCs like ARX,
There's novel TKIs.
And novel TKIs that are CNS penetrating.
And looking really good as monotherapy. Happened to see some data on one of those. So talking about studies in the future or studies that are soon to read out, are there any HER2 studies, metastatic, that you're looking forward to seeing?
Yeah, I think the bispecifics are really cool, so, and then combination as well. We've done some preclinical studies at WashU where if you incorporate ADCs, TKIs with ADCs, you may allow for better internalization and perhaps better responses and durability. So I think combination regimens are going to be interesting. I think we really need to understand better what are resistance mechanisms to all the therapies, so that we can, start to think about what are the new next generation of therapies that we need to bring forward, that are targeting HER2.
I would add to that, we do have some studies that are should read out soon with PI3 kinase inhibitors. We do have the oral SERD inhibitor. I think persevera with giredestrant that are also behind that we would need to see what those readouts are and how it impacts what we do.
I think at ASCO we had data with gedatolisib.
Yes.
And so that's a PAM pathway inhibitor, and the data was quite impressive. Usually when you combine PI3K inhibitors with, or even mTOR, like the everolimus, the ancient everolimus trials with HER2 blockade, it can be quite toxic. So to have these less toxic therapies and available, I think, especially for tumors that are PIK3CA mutated, we've already commented that those tend to be more aggressive. So definitely exciting times.
So as we wind down, what is your main takeaway to the audience, but your collaborators and or referrers in regards to DB09 and the whole landscape of metastatic HER2 positive breast cancer?
Yeah. So I will say that this is the first time in over a decade that we have seen a shift in the first line setting. And I do believe that we are going to need to be more precise in terms of identifying biomarkers to really guide us in, what's the right treatment for the right patient. And so I do think that it's really exciting times because we have a lot of options, we have a lot of approaches, and we know that some patients can do very, very well with one approach, and others that have more aggressive, disease, they may require a different approach. And so this is really the time that we're going to have to use, those biomarkers and identify biomarkers. Even last year, there was some data looking at the HER2 DDX and high ERBB2 score. So in tissue specimens from CLEOPATRA. And if we see high score, then those patients had a more durable responses or longer PFS as compared to low. So I think it's really typically, we've started to use genomics to help determine, therapy options for ER positive, HER2 negative. I think this is the start of really needing to develop biomarkers aside from just HER2, the presence of HER2 amplification or positivity to really identify the best treatments.
So I totally agree with that. One of the other things that we don't have a full understanding of is those patients almost all eventually progress on this regimen.
Right.
And knowing what the resistant pathway is.
Yes.
Is it to the payload? Is it to the target? Can help shape what the next drug would be and whether or not we can use that as a reason to select one trial over the other. Now that we have all of these trials in the HER2 positive space, which is excellent for our patients, and they're doing good for so long, are there elements of these trials that might affect sort of real-world treatment approaches?
I think they're related to, what are we going to do after?
In regards to Patina, HER2 CLEOPATRA, let me be more specific. When I think of where I would use these, because tucatinib will be approved, how do I institute these in the first line setting? Is it HER2 CLEOPATRA for the hormone receptor negative? Patina for the hormone receptor positive? In a real world setting, just trying to help our audience here. How do you see that you put all of this together?
So when we looked at the HER2 CLEOPATRA, the delta for PFS, it was more significant for those, and the hazard ratio, right? It was more significant for those who had hormone receptor negative. So it was a little bit over 12 months. The PFS was much lower for just THP, that arm. And so
12 months, I think.
And so in my mind, just looking at the differences by hormone receptor status, I was thinking, if those patients had gotten THP, then I would bring in tucatinib But those are all patients that after DB09, they may be patients that we would have given the DB09 regimen, right?
Yep.
So then the question is, if we eventually go to maintenance, are we bringing in tucatinib there or not?
Yeah.
Or are we going to reserve that for the next line with HER2 climb right? So for the hormone receptor positive, I really think that the Patina regimen is going to be critical. And that's going to be an important regimen, but also thinking about all of the patient factors that we've talked about, disease-free interval, pace and tumor burden, is there CNS disease or not, to really determine if I'm going to go the DB09 route or if I'm going to do induction THP followed by maintenance Patina.
You made a reference here that I think is a very important consideration. If you use all of these drugs and targets in the first line, what happens next?
Right.
Because again, this is an incurable disease for which we do anticipate progression at some point.
Right.
So if you use tucatinib up in the first line, does HER2 climb go away?
Right. Yep.
If you use an induction, if pertuzumab gets used with T-DXd, CLEOPATRA goes away. And what do you do for those patients? So all of that is so very important. I really just want to thank you for this wonderful in-depth conversation.
Great.
And I hope the audience enjoyed it as much as I did and got something from it. So thank you very much.
Thank you.